Hi, good afternoon. My name is Scott Canna. I am a pediatric rheumatologist and a physician scientist at the University of Pittsburgh and UPMC Children's Hospital of Pittsburgh. And I've been asked and am delighted to talk to you today about my impressions on auto and hyperinflammation, which are some things that I'll describe. Just to go over the layout of this talk, this is mostly focused to a sort of scientifically interested but lay audience. But hopefully there'll be plenty of time for discussion and questions afterwards, which I believe there's a mechanism that those get submitted through that we can address to the level of depth that seems appropriate. All right, without further ado, that's the slide. There we go. So often people will start talks like this with a story, and it's usually this miraculous success story of a very sick patient, often in whom we will discover, or other groups will discover, a genetic cause that will indicate a specific treatment and a really dramatic response. And those kinds of stories are great, but they tend to get published. And the motivation behind what I do and what many others like me do is not so much the great success stories, although obviously that is the goal, but really to continue to work on the patients in whom things aren't quite so clear. So I'm going to present a couple of those real quick just to illustrate the kinds of diseases that we're talking about. So the first is a delightful young man who I met soon after I came here to the University of Pittsburgh and UPMC Children's from the NIH. And so this young man had a funny rash that started when he was about 2 weeks of age. It was largely pink, like you see here. Hopefully you can see my cursor. It may have been painful. He was a very young guy when this started, and so not always able to explain, and largely affected his face, arms, legs, and buttocks, somewhat sparing his chest. Eventually, this rash sort of persisted well into weeks, months, and now years of his life. And finally, we got an MRI and found that the rash had a lot of inflammation apparent on his MRI, and that inflammation extended all the way into the muscle layer, some of this lighter color that you can see here, suggesting that this was a fairly deep rash. Accompanied by this, as this young man grew, it was noticed that he seemed to have this funny loss of fat, largely on his face, arms, and legs. This is a name called Lipodystrophy. And this largely followed the pattern of where his rash had been most severe. So in terms of trying to make things better, he had really no response to antihistamines. I'm sorry it was cut off, but some specialty anti-inflammatory medicines that I'm sure many of our audience are aware of, like anakinra, which is an IL-1 blocker. He did have a nice response to steroids, but at relatively high doses. And so like many patients that we try to take care of, he was somewhat stuck on steroids and looking for better ideas. So that patient is still ongoing. He's doing well on a specialty, a more specialized drug called a JAK inhibitor. But we still don't have sort of a smoking gun genetic hit for him, and are still very much trying to understand exactly what his disease is. So this other story is a bit more tragic. This is a young man I met when I was a fellow. He presented as a previously healthy 5-year-old male with just a prolonged high fever that over time progressed to include some low cell counts, some clotting problems, some liver damage, elevation of this blood test called a ferritin to extremely high levels, and unfortunately shock, which is the physiologic state of when you're not delivering enough oxygen to your organs. And requiring quite a lot of intensive care. So an extensive evaluation, as you can imagine, in this young man for infection or cancer was completely negative. And so I'll read this to you. It's among the more tragic things I've read. So there was significant improvement in his condition once on this therapy, a lot of anti-inflammatory therapies, but the road was very bumpy. When he was awake, he tried to smile, tried to talk, and never complained once. He only cried 3 times, twice for his legs, and the third time was in his final days. He wanted to go home. After about 100 days of fighting a good fight, his tiny, frail, and damaged body could not keep up with his big, beautiful spirit. And these are the kinds of stories that continue to inspire investigators like me to do a much better job for our patients. So we're talking about disease of the immune system. And so what is your immune system there for? Well, the main reason we have an immune system is to protect us from infection, either to fight infections or prevent them from happening. And so, you know, your cartoons of different kinds of bacteria, viruses, fungi, but that's not the only thing your immune system is there for. It's there to help you heal wounds. And we're increasingly appreciating the extent to which it's important for surveilling for the development of cancers and killing them before they get too big. And so when we talk about inflammation, we're talking about, you know, one of the things that the immune system does to try to combat infection or, you know, in the context of wound healing or cancer surveillance. And so classically, inflammation is characterized by these, you know, 4 sundry characters here: heat, redness, swelling, pain, and loss of function. And so when we say inflammation, we mean the collection of several of these things in the same place at the same time. Now, the immune system is arbitrarily divided up between the innate and the adaptive immune system. And this is relevant for understanding how we think about a person's disease. The innate immune system is really fast. It's there and ready to respond at the drop of a hat. It largely responds to danger signals, either damage in your body or patterns that are in microbes that signal that that's a microbe that is misbehaving or in a place it shouldn't be. They have a limited repertoire, meaning you can't respond to everything a microbe might throw at you. The responses are similar every time. And I think that the innate immune system also includes barrier mechanisms like the mucus and the barrier tissues in your sinuses or in your intestinal tract. By contrast, the adaptive immune system is a bit slower. It is informed by danger, meaning you don't get much of an adaptive immune response without an innate immune response. It has a functionally unlimited repertoire, meaning the way that the adaptive immune system sort of generates cells of either B cells or T cells, the adaptive immune receptors on those cells have an almost unlimited number of different things that they can respond to. And almost, maybe most importantly, the adaptive immune system demonstrates memory, meaning re-challenge with the same infection gives you a faster and more robust response than the first challenge. And so obviously the innate and adaptive immune system work together. But when they go wrong, we often will divide the ways that they go wrong into several overlapping categories of immune dysregulation. And so you've probably heard of autoimmunity and autoinflammation, atopy and allergy. This is, you know, asthma and food allergy and those kinds of things, as well as, you know, severe allergic drug reactions. Immunodeficiency, people who have too many or too severe or weird infections. And then lymphoproliferation, in which many people would even include a number of different kinds of cancer. And I throw this up in this way because there is actually quite a bit of overlap. When the immune system gets confused or goes wrong, it doesn't just pick one category of immune dysregulation. So, you know, when you're thinking about inflammatory or immune diseases, I think it's actually harder to think about diseases that are not immune or inflammatory related. So all of the diseases that I put up here, most of them quite common, the main driving problem is a dysregulation of the immune system, whether it's an infection and the immune response to that infection is causing some problems, like often in Lyme disease, especially latent Lyme disease, whether it's a classically autoimmune disease like type 1 diabetes, whether it's a more complicated sort of barrier immunity like ulcerative colitis or eczema. And so these are some of the most common ailments that we deal with, and all of them largely boil down to problems of the immune system. So to get back into the meat of our topic, I'm going to talk about autoinflammation and hyperinflammation and hopefully define those in a reasonable way. And these are the diseases that we'll discuss today. That is a joke. I'm sure there's thunderous laughing in the audience right now. That's also a joke. So no, there's no way that we could cover all of the autoinflammatory diseases. And this is a constantly updated but absolutely spectacular comparative chart put out by the Autoinflammatory Alliance that I'll link to later, that goes through all the different kinds of symptoms, all the different kinds of diseases and rashes. And it's way beyond the scope of what we can discuss today. So in that vein, this is also going to be my last slide, so don't hurry to rush and write everything down. These are the resources that I use on a regular basis to help me navigate the massive number of different diseases there are, both rare and not so rare. These are some of the foundations who I've had the pleasure of interacting with, and who I think hopefully some of their members are joining us today. Here are some online resources: the National Organization for Rare Diseases, a website put out by Children's Hospital of Philadelphia called immunodeficiencysearch.com, and then a NIH resource called Online Mendelian Inheritance in Man, where you can look up practically any rare disease or gene and learn a whole lot more about it and get links. There's a mobile web app for trying to classify immune dysregulation diseases, some websites from our European colleagues. And so I find all of these tremendously helpful. There's also been a few books that I think have recently come out that I think are relevant to this effort. The Textbook of Autoinflammation and Cytokine Storm Syndromes. I've been lucky to be involved in all of these, but they involve a great number of really the experts in both fields, and they are reasonably current. So I encourage you to check those out. Okay, so definitions. This is not the kind of autoinflammation that we're talking about, not a barbecue, but persistent inflammation that's not explained by infection, cancer, or the effects of autoantibodies or antigen-specific T cells. Now that seems like a big, gobbledygook. In practice, what we really mean are diseases that are, canonically caused by single gene defects in innate immune activation. So you remember we talked about the innate immune system that was fast, that was inflammatory, that was responding to danger and damage. And there's specific innate immune cells that we talk about, like neutrophils and macrophages. And so when we talk about autoinflammation, we're generally talking about diseases of the innate immune system. And so with so many diseases, how can we possibly organize them all in a way that's digestible for physicians trying to treat these children, or parents trying to understand what their kid has? And so the most simple way might be just by their clinical features. And so, you can organize by things like rash, describing whether the rash is sort of full of pustules or full of hives, or, kind of flat and swollen and red, or causing lipodystrophy, like in the patient we talked about, or primarily centered on the fingers. So this is just pictures of the rash. You can also talk about length of flares. Some flares are shorter, longer, some are periodic, some are episodic. You can look at some of the special features that seem to occur in specific diseases, like eye inflammation or brain inflammation, or this funny bony overgrowth of the knees that can occur, or large joints that can occur in sometimes rarely in a couple of these diseases. Or you can sort of look for the chronic things that can develop and that need to be prevented in these patients, like amyloidosis, which is a kidney problem, or hearing loss or bony overgrowth. Another way of organizing these diseases is by the misbehaving cytokine. And this really came about because the pathology driving a lot of these diseases is quite different, even if the rashes can look very similar. And so even though organizing by clinical features makes the most intuitive sense at the bedside, it often doesn't tell you what the right way to work the patient up is, or the right drug to use is for that patient. So right now, the best way of sort of dividing this group of autoinflammatory diseases up by cytokine is with these three cytokines or pathways: the IL-1 pathway, which is associated with the inflammasome and a bunch of diseases called inflammasomopathies; the interferon pathway. Interferon is a cytokine that largely evolved to help us fight viral infections; and then an NF-kappa B TNF pathway that's a bit more broad, but has some common features that we'll touch on. So to summarize sort of the overarching trends of these three, IL-1, interferon, and NF-kappa B pathways, clinically, the IL-1 group is sort of the first described autoinflammatory diseases. They have episodic fevers, they have rashes, there may be a subclass that also has high IL-18, and they tend typically to have a rapid and fairly dramatic response to blocking IL-1. Many, but certainly not all, of the mutations associated with IL-1 diseases are gain of function, meaning the mutation causes that gene to be hyperactive. And functionally, we can't do this on a clinical basis, but in the lab, we can often look at these patient cells or look at their mutation and find that there's increased activity of this innate immune thing called the inflammasome, which generates so much IL-1. The interferonopathies, by contrast, tend to respond not at all to IL-1 blockers, but often more to this class of medicines called JAK inhibitors, which you may have seen commercials for, drugs like tofacitinib on TV. Many of these patients will have calcifications in their brain, specifically in a part of the brain called the basal ganglia, and that seems to be a fairly common finding among several of them. And then in terms of their other clinical responses, they can have acral, which means sort of the tips of the fingers or toes, or sometimes even the tips of the nose, blood vessel problems, so vasculopathy. They can also have lung problems, and they can develop fibrosis. Genetically, it's quite variable. Some of the mutations cause hyperactivation. Some of the mutations cause a loss of an important gene that's important for regulating inflammation. Some of these diseases are caused even by more than one gene. And functionally, we can try to evaluate whether this is the type of disease somebody has by looking in their blood for something called an interferon response gene signature. This is not yet clinically available, but a number of places are working hard to bring that online. And then this final category of TNF or NF-kappa B mediated diseases has a lot of sort of broad symptoms, granulomas in some diseases, eye inflammation called uveitis, oral ulcers in others. Many, but certainly not all, have a substantial response to blocking another inflammatory cytokine called TNF. Many of these diseases also have a substantial overlap with immunodeficiency. And so when you see a child who is both having infections and a lot of inflammation, this is a class of immune dysregulation you might think of. Many, but again, not all of these are loss of function mutations. So, or better yet, maybe not loss, but just change of function, because it's such a complicated pathway that it just gets a little out of whack and things run in different directions. And functionally, there's a pathway called ubiquitination, which is something that happens inside cells to transmit signals or to tell certain proteins to be destroyed. And this can often get out of whack in these NF-kappa B TNF diseases. But in general, these are the overarching patterns, but there are lots of exceptions in each. So obviously I don't want to not talk about hyperinflammation. And so hyperinflammation has been getting a lot of press lately in the context of the SARS-CoV-2 pandemic and patients getting severe COVID-19, and now this newer entity called, depending on which side of the pond you're on, MISC, mostly in the US, or PIMS-TS in the UK. These broadly sort of fall under an umbrella we sometimes call cytokine storm. And so here's just, a storm approaching the playground and some of the cytokines that can be part of it. So what you call it, this cytokine storm, often depends on, what context it's occurring in. And so, if it's an infection, or if you're not sure, or if you're in our intensive care unit, you might call it culture negative sepsis, or viral sepsis, or hyperinflammatory or hyperferritemic sepsis, because the features of shock and multi-organ dysfunction of hyperinflammation overlap quite a bit with sepsis. In hematology and oncology, there's two contexts in which you see this. One called hemophagocytic lymphohistiocytosis, which has a very prominent genetic cause, especially in young children. And then more recently, something called cytokine release syndrome, which can occur in certain kinds of cancer immunotherapy, where the immune system gets programmed to be really revved up against the cancer, but can also cause a cytokine storm. And I'm a rheumatologist, and so our patients, when they get this sort of overwhelming systemic inflammation, we tend to call it macrophage activation syndrome. So what you call it often depends on which of us got there first, and what bugs you did or didn't find. And so from understanding the mechanism of what's happening, these names are not always so helpful. So what do we mean by hyperinflammation? Well, largely it's quite a broad, umbrella of overwhelming systemic inflammation. And so this is a figure that we made for a recent editorial about COVID, where it includes things like in rheumatic disease, systemic GIA, this is macrophage activation syndrome, different forms of this HLH that we discussed, a large group of infection associated, including virus infection. And then I'm sort of putting severe COVID-19 and MISC here as part of a SARS-CoV-2 bubble that overlaps with something called ARDS, which is acute respiratory distress syndrome, which is severe lung inflammation, often in the context of infection. So clinically, the patients all kind of have many or most of these features: high fever, low cell counts, abnormal clotting, liver damage. There's that ferritin again that we discussed before, but other biomarkers like LDH. And too often these patients can progress to shock and unfortunately sometimes death, much like in the case we described. So another way of looking at this, and I apologize again that this is quite complicated, but this is trying to understand which way you're headed in a cytokine storm, is something called a systemic inflammatory response. And that's sort of the big circle here, which includes responses like in severe trauma, in sepsis. This is something called compensatory anti-inflammatory response syndrome. So it's almost the opposite of hyperinflammation. And then this orange bubble here is kind of the group of diseases we're discussing, where you have different kinds of infection-associated HLH, including one called EBV, which is caused by Epstein-Barr virus, which is a common culprit of virus-induced hyperinflammation. Primary HLH, which is often caused by mutations in genes like perforin, cancer, malignancy-associated HLH, this cancer treatment-associated HLH or MAS or cytokine release syndrome, and then macrophage activation syndrome. And so while they're all sort of a similar ilk, they often can be quite distinct. So one of the interesting things that, as I've been learning more about these diseases and studying them over the last decade or so, is the extent to which there's very little overlap between the autoinflammatory diseases, even though we know that they have a lot of excessive cytokine production and systemic inflammation, and the hyperinflammatory diseases, which are these diseases that result in a sepsis-like presentation with multi-organ failure and shock and death. And so the way I envision these hyperinflammatory syndromes and the way that can be caused is really focused on three things. So if you're in the middle of the storm, and let's say you're a cruise ship trying to stay afloat, there's three contributors to the badness that you're experiencing. One is just the storm itself, whether it's a cancer treatment like CAR T cells or bacteria or certain particularly bad viruses, especially sort of hemorrhagic viruses. You may have heard of Ebola or dengue. The disease that they cause often looks a lot like hyperinflammation, or even just the immune response to cancer itself. Or you can have a problem with the boat. You can have a problem with your own immune response, and that's going to make it hard for you to stay afloat if your own immune response is helping to sink you. And finally, you may not be able to turn off the storm, but you can bail water. And so how exactly can we sort of attack each of these three areas? Well, you can attack the trigger. If it's an infectious trigger and you can give the appropriate antimicrobial, whether it's antibiotics or antivirals, then that is going to be one of the most effective ways of keeping your ship afloat. If this occurs in a rheumatic disease, often treating that underlying rheumatic disease is quite helpful. If you have a hole in your immune system or a hole in the regulation of your inflammatory response, you can try to replace the thing that is missing if that is something that is available as a drug, or you can kind of go through the somewhat dramatic but often life-changing and curative process of switching out your whole immune system for somebody else's in the form of a stem cell transplantation. And then finally, you can try to bear water and try to ride out the storm. And this is where we as rheumatologists try to get crafty using things like corticosteroids or IVIG, or the ever-increasing number of specific cytokine blockers, and finally some of the more old-fashioned but nevertheless sometimes really helpful immunosuppressants. So to try and enforce some logic on this process, in collaboration with a number of my colleagues, we've put together something that we're calling the Immune Dysregulation Diagnosis and Treatment Program. Here's our website. Here's an email you can call, you can send messages to, and our phone number you can call. And the idea is really to improve the recognition, diagnosis, treatment, and monitoring of immune dysregulatory diseases, be they immunodeficiency, allergy, autoinflammation, autoimmunity, or boy, that's complicated. We really need to sort of work together. And so, we have three main goals: outreach, education, and training, and that includes talks like you're suffering through right now. Multidisciplinary care, which we've always sort of informally been doing, but we want to do that more formally and more sort of robustly, and to continue to learn from each other and from what our patients are trying to teach us. And finally, in some of our most complicated patients, it is the case, I believe, that research constitutes some of the best patient care. And so integrating research in at as many different levels of this as we can, in obviously the most ethical and productive way possible, is also one of our main goals. So these are the members right now of our immune dysregulation team. I'm putting the dunce hat on myself because I can't sort of speak highly enough of the other members of this group, all of them experts in their own right, and representing a number of different specialties. And so this is the village that we hope to bring to bear on our most complex immune dysregulation patients. And so finally, there are just too many people to thank. This is one of my favorite pictures. This is from an old cathedral in France, and it is the first representation I can find of standing on the shoulders of giants. And so these are 4 of the New Testament apostles sitting on the shoulders of 4 of the Old Testament prophets. And if they have seen anything at all, it's because they've sat on the shoulders of true visionaries, and there are just too many to mention in both the fields of auto and hyperinflammation, but I'm unbelievably grateful for their contribution. I'm unbelievably grateful to all of you for your attention, to the people in my lab, the Canna lab, pun painfully intended, some of our different funding sources, and of course to this program that we're just getting up and running. And so I'm going to leave you with some of these online resources while we try to have a bit of a discussion so that you can write them down and search them while we talk. All right, so this is the point at which I'm going to open and see, are there any questions? All right, so this is a question from David, who asks, since caspase-1 doesn't selectively process IL-1 over 18, are there any IL-18 centric pathologies? So I swear this is not a plant. It's funny you should ask. IL-18 is one of the driving things that my lab studies. There are a few what we think are IL-18 centric pathologies. How would you define an IL-18 centric pathology? Well, maybe the best way would be to say, well, are these diseases that get better when you block IL-18? And there are a few that we're investigating that, but we're still very early days. There are a number of diseases where the levels of IL-18 in the blood, which actually is a fairly useful biomarker and something that we can send clinically these days. In lots of inflammatory diseases, the level of IL-18 is a little bit high. Normal is up to, let's say, 550. And so maybe you'll find a patient who is 1,000 or 2,000. But then in some diseases, you'll find that a patient, even when they seem well, might have a level in the 40, 50, 2, 3, 4, 500,000 range. So much, much, much higher than even other inflamed patients. These tend to be the patients that we previously called macrophage activation syndrome. So patients that have this hyperinflammation in the context of systemic JIA or adult Still's disease, and then a few genetic diseases, among them NLRC4, and now maybe some patients with XIAP deficiency or very specific mutations in a gene called CDC42. So as we measure more and more, I think we're learning more and more. It is certainly not all of the hyperinflammatory patients that have IL-18 as a problem. But yes, this is something very near and dear to my heart. You're right, caspase-1 doesn't selectively process IL-1 over 18. It probably has to do with how much of the substrate there is for caspase-1 to activate. So the caspase inflammasome can't cleave IL-18 if there's no IL-18 present in that cell, or it'll cleave a lot of IL-18 over IL-1 depending on what the substrate amounts are. Okay. This is a question from Abigail. It's hard to tell exactly where these questions start on here. Graduating in August. I'm in remission from juvenile dermatomyositis. Congratulations. I hope it stays that way forever. Treated at Children's. Would love to continue to learn more about the topics we discussed today. What tips you might have for a student who's hoping to go into this field? Fall in love with immunology. You know, for me, it's something I couldn't help. But I think that there's a lot of ways to access this. I mean, you saw the different experts. You can study inflammation for the rest of your life as a neurologist, as an intensive care doctor, as an infectious disease doctor, as an oncologist, as a pulmonary doctor. You know, inflammation is in every part of the body. So I would continue to stay sort of curious, read up on things, follow people on Twitter who you know, are working in areas that you find interesting, and keep up on their stuff. Hit some of these resources that I've just mentioned that get updated and they get linked to other resources. So I guess I would just say, you know, the field of human immunology continues to just advance at a really rapid pace. And so as long as you stay interested in that, it's never going to really be irrelevant. So Amanda asks if autoinflammatory flare can be severe enough to cause sepsis. This is a very good question. They're all very good questions. It's a little challenging and it comes down to semantics. Sepsis is defined as this sort of systemic inflammatory response syndrome, you know, symptoms like fever and high heart rate and, you know, some changes in the labs in the context of known or presumed infection. So if you are quote unquote septic, you really can't be autoinflammatory because the explanation for your inflammation is infection or response to infection. But it gets fuzzy because if you are someone who has an autoinflammatory mutation, you might have an exaggerated response to an otherwise boring infection. And some people think this is the basis for almost all rheumatic diseases, that there's some infection that we just can't find and the immune response has gone haywire. There are certain autoinflammatory diseases that have really severe systemic inflammation that can be as life-threatening as sepsis. Something called deficiency of IL-1 receptor antagonists. Some of those children have presented really in extremis. And then these HLH and MAS mutations, many of these children, unfortunately, have really had extreme presentations. So yes, the answer to your question is yes, but the definitions get a little fuzzy. Among my favorite parent advocates in the entire world, Karen asks, Karen is the driving force behind the Autoinflammatory Alliance. Oh no, she's that is a different Karen. This is also one of my favorite parent advocates in the world. A different Karen from Toronto. Is my research being conducted like NIH, where you bring in patients from all over the world? Somewhat, Karen. I am so sorry for confusing you with my other favorite Karen. And how are you doing? We are happy to bring in patients. We don't have quite the resources that they have at the NIH to help people travel to us. And that's among the reasons that we still collaborate so much with the many great autoinflammatory investigators at the NIH, because there are things that we can do here that they can't do at the NIH, like see patients that are getting sick for the first time, or really, really sick, really young patients, things that the NIH doesn't always do so well. And then there's certainly going to be lots of things the NIH does really well, like facilitate these patients with these ultra-rare diseases coming from all over the world. So yes, we very much try to collaborate in that way. And certainly if there are folks from around the world who are interested in coming and participating in our research, you know, we have some resources here to help them do that, and certainly have some specialties here in Pittsburgh that are a bit unique. So another, this is a walk down memory lane. Dori, who has an absolutely adorable daughter who I met as a medical student, and another sort of inspiring story. Is there anything in the pipeline for NOMID, which stands for neonatal onset multi-system inflammatory disease, which is caused by an inflammasome hyperactivating mutation, that wouldn't require 2 injections a day, but a medicine that is just as good? No. 16 years old now? No. Okay. That makes me feel old. Thank you for your question. So Dori's question is in response to this IL-1 blocker, anakinra. It has a very short half-life, which means you have to take it at least once a day, and many patients need to take it more than once a day. And it has to be given as a shot because it's a protein. It can be given IV as well, but you can't take it by mouth because you'll digest it just like you'll digest a piece of chicken, and then it won't work. So yes, there are drugs that work in a very similar way to anakinra. One called canakinumab, another one called rilonacept, that can be given every 2 to 4 to maybe 6 weeks. These often work pretty well, but NOMID is a somewhat severe disease, and anakinra tends to get into places maybe a little bit better than those other drugs do. But Dori, there is a really broad pipeline of drugs that are specifically trying to inhibit the NLRP3 inflammasome, which is the thing that's mutated in NOMID, as well as other drugs that are specifically trying to inhibit caspase-1 or another molecule that's part of the inflammasome called ASK. So I think the future looks bright for medicines that will work as well as anakinra, but are much better tolerated. And thank you for listening, and thank you for your question. Michelle asks, can you discuss the role genetic counseling and testing has played in your clinical approach? Do many of your patients undergo genetic testing? Also not a planted question, but boy, I don't think that there's a lot of controversy among investigators and physicians like myself that genetic counseling is critical, genetic testing is critical. Genetic testing is getting cheaper and cheaper, and so we're doing it more and more clinically. There are 2 absolutely fantastic members of our IDET team who are genetic counselors, whose advice and input is absolutely invaluable. My personal bias is that we should be collecting genetic information on as many patients as we can, and even if we can't quite interpret that information right now, your DNA code by and large isn't going to change very much. And so as we learn more, we can revisit it and start to understand more about genetic predisposition. Certainly, genetics doesn't explain everything, and especially for diseases that have a later onset, genetics may not be as much of the overall cause. But I would say most of the patients that we see through IDET, we at least consider genetic testing. Sometimes it's a focused genetic test because we have a fairly focused suspicion. Sometimes it's all over the place, and so we try to sequence broadly. So it's a moving target, but not going to be any less important than it is now, and has been really revolutionary in understanding how we understand these diseases. All right, I can't tell if I'm rambling because I get no feedback from the audience, but here we go. Next question from David. How can adult patients like me get involved in what you're doing? I know I'm pediatric focused, but what can adult patients do to help the cause? Well, research protocols, most of them don't have an age cutoff. Certainly when I was at the NIH, we didn't have an age cutoff. I do often, not often, but sometimes see adult patients in my pediatric clinic, if you can stand a waiting room with choo-choo trains in it, on a sort of consultative basis to say, this is my impression of what's going on, and then I can help a person's adult rheumatologist better manage or better optimize their treatment. And that's something that I do a couple times a year, and I'm happy to do. And in that process, often we'll enroll those patients into our research studies and try to learn what they're trying to teach us. So just because your disease is onset in adulthood doesn't mean it's not autoinflammatory. And as we as doctors do a better job, more and more of our autoinflammatory patients will grow and thrive long into adulthood, and they'll need care as well. So it is an important resource. A number of my colleagues are also adult and pediatrics trained, and so bridge that divide as well. Monica asks, how would prolonged steroids affect a 2-year-old? So this is a very fair question. We spoke a lot about steroids. Steroids go by a number of names. We can call them corticosteroids or glucocorticoids. There's a lot of different kinds of medicines that are steroids, whether it's topical steroids like you might use for eczema, or inhaled steroids like you might use for asthma, or systemic steroids either by a pill like in prednisone or dexamethasone, or you can give these things IV. Steroids are sort of the classic double-edged sword in treating diseases. We use steroids to treat everything practically, from cancer to asthma to autoinflammatory disease, because they work. I often present as an exercise to our fellows because it keeps me up at night. How would I practice in a world where we didn't have glucocorticoids? It would be much harder. We would see a lot more pathology and a lot more organ problems, and we'd have to be a lot smarter in how we treat the immune system. But as I said, it's a double-edged sword. So in the short term, steroids are unbelievably effective and quite safe in calming down all different kinds of inflammation. In the long term, they have all the side effects, from immunosuppression to they're bad for growth, they're bad for bones, they're bad for brains and memory. They're bad for your sort of diabetes risk. And so our goal is often to use steroids, often fairly aggressively at the outset, and then try to get people off of them. And so all those side effects that I mentioned, it depends what you mean by prolonged, and the dose also matters in terms of the side effects of steroids. But you also need to remember that sometimes, a patient's disease is so severe that they kind of need those steroids to keep the disease from causing worse problems. So, one of the main things that we all try to do is to find better treatments than steroids, not necessarily things that work better, but that are safer. And so I think that that's a prolonged conversation that's very specific to your child that you should have with your doctor, whoever is prescribing those steroids. Okay, Sandra asks, if an IL-1 blocker works on the inflammation, does that give a good direction towards a diagnosis if genetics fails to give a proper answer? Often. I would say that's the case. So we have these drugs, IL-1 blockers. I've mentioned anakinra, I've mentioned canakinumab, I've mentioned rilonacept. I personally, and many of my colleagues as well, will often try to learn more about someone's disease based on whether or not they respond to IL-1 inhibition. That first patient that I presented that had the funny rash and the lipodystrophy had absolutely no response to IL-1 inhibition. And so that helped move my understanding of him into a different category to say, okay, this is probably more maybe in the interferonopathy category, or maybe in the NF-kappa B opathy. So just because an IL-1 blocker doesn't help you doesn't mean you're not inflamed. It simply means that that pathway is not a major driver of your disease. And so I think sometimes it gives ballpark diagnostic information, particularly in some of these patients where there's not an obvious genetic answer. Again, I have no feedback on whether these answers are sufficient, so I guess I'll just move on. Okay, so Ellen asks, for patients like myself who have failed available treatments, how far away are other IL6 inhibitors like olokiumab and elsalimumab? There are probably more than 2 that are FDA. There are 2. So IL6 is another inflammatory cytokine. And there are a number of IL6 blockers. Tocilizumab was the first that was put out there, and that gets used for systemic GIA as well as a number of other inflammatory diseases, vasculitises. There's been quite a lot of hoopla about tocilizumab and other IL6 inhibitors for COVID. There's another IL6 inhibitor called sarilumab that works in a very similar way. I will be honest with you, I don't know how far in development some of these other IL6 blocking compounds are. Some of the problems with the current IL6 inhibitors have to do with side effects. Some folks will have infusion reactions, which can be quite severe, even if they respond quite well to the medicine. And so it's in some patients quite heartbreaking because you have a medicine that's working well, but then they're having an immune response to it. And so are there other drugs that they won't have an immune response to, an allergic or atopic immune response to, that are coming out? And there certainly is a pipeline. I can't say how close or how far they are. Just for those who are sort of mind boggled at the names, if a drug ends in MAB, that stands for monoclonal antibody. That means it's among a kind of biologic drug. And so when we talk about canakinumab or tocilizumab or olokiumab, these are all monoclonal antibodies that we use as drugs. Cecilia asks, can you have an autoinflammatory disease if there's tissue inflammation, but your labs always come back normal? The answer to that is yes. Autoinflammation just refers to a type of immune dysregulation. And so that inflammation doesn't have to be so widespread. It can be in a local place, like in the skin, or even some of our patients that have arthritis. You can have an autoinflammatory arthritis that doesn't necessarily cause systemic inflammation. I will say that it is sometimes hard to tell whether a rash is even inflammatory. People can have rashes that are caused by local nerve dysregulation, and those tend to be the rashes that sort of come and go really quickly. It's not always so convenient to get, but sometimes a skin biopsy in that situation can be quite helpful, not just for illustrating that there is inflammation, but again, for telling you what flavor of inflammation that might be, whether it is innate immune system cells or adaptive immune system cells, or a little bit of both. And as you point out, what kinds of things are maybe damaged. If it's a vasculitis, you should see damage to the blood vessels that's in that biopsy. So even though biopsies are not particularly convenient, they can often provide a lot of information. Shira has a fairly long question that I want to do justice to. One, is there an understanding on why some patients have repeated flares, whereas some patients may have one and then seem to be done, like in monocyclic SGIA? Does the patient truly have the autoinflammatory disease that can still flare at any time? This is an important question that continues to boggle us. What causes flares? What causes some people to have a monocyclic course where they can present and be called systemic GIA, and then things sort of quiet down and stay better, and other people have a much more chronic course? We don't have great answers to these questions, and this is why research is important. Not just the sort of more basic research that people like me do in my lab, but epidemiologic research and clinical research to try and understand things. There's a collaborative network in the US called Canna that has an autoinflammatory focus to it, and they're working on building out a registry so we can simply follow patients and try to figure out what are the patterns that might distinguish someone with a monophasic versus more chronic course. Clearly, there are triggers to flares that we don't understand. A lot of patients, especially in my experience with systemic GIA, say that stress or sleep deprivation trigger their disease. And I don't think we have some hypotheses, but not a good understanding why that might be or what we can do to address that. My attempts to write prescriptions for no stress are unfilled. And the second part of your question is, how perfect does blood work need to be in order to have the disease totally controlled? If certain markers are consistently only slightly out of range but no clinical symptoms, is that good enough? This is a fairly nuanced question that I think that you want to pose to whoever's helping take care of you or your child. In a disease like systemic GIA, I personally believe that there are a number of markers of smoldering, what I'll call smoldering disease, where certain things like the C-reactive protein or the platelets might look okay, but that other things might look a little amiss. And the ones that I tend to look at are things like a D-dimer, which is a sign of abnormal clotting, which can be quite sensitive. Another one called an aldolase, which sometimes can be elevated even if patients feel well. And the Karen that we just spoke about knows this better than I do for sure. And then, near and dear to my heart, this IL-18, that patients with systemic GIA who continue to have very high IL-18 levels may be at higher risk for subsequent flare. But that is still a research question. Alice asks, are there any links between CAPS, which is cryopyrin-associated periodic syndromes, of which NOMID is a part of, and leukemia, or IL-1 blockers in leukemia? I'm a patient with Muckle-Wells syndrome, and I've been on anakinra and canakinumab. I'm not going to use trade names. Not to my knowledge. Certainly not as many people have gotten IL-1 blockers as have gotten TNF blockers, which you've seen commercials for TNF blockers that are used for arthritis and psoriasis and other kinds of things, inflammatory bowel disease. But a large number have, and certainly patients such as yourself tend to be on these drugs for a very, very long time, sometimes the rest of their lives. And I am not aware of, and don't have any personal experience with anyone developing a leukemia or a lymphoma or other kind of cancer, certainly not at a rate out of proportion to what we might see in the general population. It's one of the reasons that we tend to reach for drugs like IL-1 blockers fairly early, because they tend not to be very immunosuppressive. We don't think that they have an increased risk of long-term or cumulative side effects like leukemia or infertility. And they tend to work fairly quickly. Their biggest downsides are probably that they're expensive. They have to be given either as a shot or IV. And that, we just don't have the whole world of experience to know exactly how people react to them. Amanda asks, can you tell us more about the ester risks of these children, specifically systemic GIA, have related to a virus like the novel coronavirus? How concerned do we need to be as parents, in my opinion, or does the risk directly depend on the control state of the disease? The honest answer, Amanda, is that we don't know. Not a lot of children with rheumatic diseases have been exposed to SARS-CoV-2, which is the name for this new coronavirus, there is a registry that encompasses both adults and pediatrics to try and collect this kind of experience. Extrapolating largely from the adult literature, there do seem to be some risk factors for people with rheumatic disease who are going to have a tougher time with handling COVID. In adults, people who are on chronic medium to high dose steroids, that seems to be one of the things that has come out as maybe being a risk factor for having a hard time. In general, it is my impression that children, even children with autoinflammatory diseases like systemic JIA, and even those who are maybe not under great control, have not had a terrifically hard time with developing COVID-19. They also don't seem to be the ones developing this post-infectious thing, this MISC. Almost all the children with MISC were patients who were previously healthy. So, one of the most interesting things about COVID is how much more severe it seems to be in adults than in children. And in that way, it seems that being a child is quite protective, even if you're on some immunosuppressive therapy. So again, I'm going to refer you in your specific situation to your rheumatologist. But in general, I think that our children have been fairly lucky in this pandemic to not have had a lot of problems with severe disease. David astutely asked, don't JAK inhibitors partially block IL6 production? They sure do. So IL6 is a cytokine that signals through the JAK-STAT pathway. And JAK inhibitors, especially some of the earlier generation, or I believe tofacitinib has a fairly good activity against IL6 signaling. I think some of the newer ones that are less so ruxolitinib and baricitinib are maybe not as good at blocking IL6 production. Right? Actually, this is, to be specific, your question says block production. These drugs would block signaling, but not production. They might secondarily block production by blocking inflammation in general. But yeah, so these JAK inhibitors have the potential to block lots of different cytokines, which again can be good or bad, depending on the context. Although so far, our limited experience has been largely positive. But it depends on the selectivity of the drug, and some of the newer ones have been engineered to be either more or less specific for certain signaling pathways. And so I believe some of the novel, more JAK1 specific ones maybe not as focused on IL6 signaling. Leah, who I also is another parent advocate, and I'm a huge fan. Have I had a patient that had a severe reaction to Actemra infusion, successfully used the sub-Q version or another IL6 inhibitor with no reaction? So this is my personal experience. I believe I have had one patient who had what we thought was a sort of anaphylactic type reaction to the infusion, who then did well on the subcutaneous form. I've not switched to the other kind of IL6 inhibitors, but I know others who have, who seem to be doing reasonably well. And so that is certainly a reasonable option. And just because you've had an infusion reaction doesn't necessarily mean that your allergy to the drug completely precludes you from getting it subcutaneously. But it's certainly something that you'd want to monitor closely. And then, oh, Karen, thank you so much. We miss you too. I'm so glad you don't really need us. Karen is also under the care of a absolutely world-class pediatric rheumatologist in Toronto, who only very rarely needs or even wants to solicit my opinion, because he's got things well under wraps, and she's so well cared for anyway. I believe that we are at time, because I believe that either I've answered all the questions, which would be great, or we're out of time. Come on in. Oh, I should put my mask on. Pardon me. Okay, should I sign out or something? Very good. Well, thank you all for stopping in. I'm going to go back to our IDAT resources. This is something we're building both for the people in the Western Pennsylvania area, but also more broadly so that we can provide better care. And thank you so much for your excellent questions.